Thanks so much for having me. Thanks for all being here still and not leaving. I know I'm what stands between you and your weekend, so I hope to provide you with some useful information. What I'm going to talk about has been discussed to some degree so far today, and I'm glad that we're all on the same page that there are important things to think about in terms of prevention. There's things that we can do probably to prevent dementia and Alzheimer's disease. I'm going to go into a bit more detail about what they are, what the evidence is, and I hope that I provide some useful information to you. So here's my title, a quick disclosure. So this audience certainly knows what a big problem we have coming in the future. So this concept of silver tsunami, our population is aging. We've done a really good job at treating acute illness. It was mentioned earlier that people can live much longer than they used to be able to, but this means that as a result, we have more Alzheimer's disease. And really understanding what we can do to prevent Alzheimer's at an earliest stage as possible is really important. So I'm focusing on prevention and modifiable risk factors. So the Lancet Commission put together a group to review the evidence and decide what are the areas where we can really make a difference and prevent dementia. And these numbers look very similar to what Dr. Schneider presented earlier, looking at the pathology, with an estimation that about 1 in 3 cases of dementia, and this includes Alzheimer's disease, could be prevented by addressing these lifestyle factors. And I've circled the ones that I'm going to, can you see the circles? You can't. Interesting. I've circled on my screen, but the ones that I'm going to talk about, which include physical activity, hypertension, obesity, smoking, and diabetes. That's what I'm going to talk about the most. There's other important factors here. So again, some of these that we want to increase, like physical activity, and others that are important to decrease to actually lead to prevention. So in addition to these, there's the circle, sorry about that. In addition to the Lancet Commission recommendations, the National Academy has put together an official set of recommendations. They got experts together and said, let's review all the literature, let's review all the clinical trials that have been done in this area, and make recommendations to the public about what they can do to actually prevent dementia. And when they reviewed all the literature, and I'm going to tell you literature or papers that were published and trials that were presented after this happened, but at least at this time, which was a few years ago, they said there's 3 primary areas where we think there's convincing evidence that people should focus on to prevent dementia. One was cognitive training. I'm not going to talk a lot about that, partially because it's very vague. It's sort of whatever works for you. It's important to do some level of cognitive training. A second was control of high blood pressure, especially during middle age, and that's really, I'm going to talk about that quite a bit today, and then increasing physical activity. So again, more and more people putting their heads together and thinking these are important areas that we need to address. So here's some data that you've seen before. I have, I think, the same part of a slide as Dr. Schneider showed earlier on the bottom. So we know there is a tremendous amount of mixed pathology. We know there are very few cases of pure Alzheimer's disease. There's probably very few cases of pure vascular dementia, a term that used to be used more frequently in people who had strokes and stroke-like changes in the brain and had cognitive problems and dementia. But now we see there's so much overlap between these two. Again, many people given a clinical diagnosis of mild cognitive impairment or even Alzheimer's disease have different types of pathology, including overlap with strokes, or what are termed infarcts on this graph in the pie chart. So again, a huge amount of mixed pathology, and this is important because even if we have an agent that might directly treat amyloid, as we've heard about, there might be something exciting in the future, we still need to think about these other aspects, not only because they might even precede amyloid changes in the brain, so might be things we can focus on even earlier, but also because they may both in parallel contribute to cognitive problems. So what am I talking about when I'm talking about vascular risk factors? So certainly these are things that we know traditionally are risk factors for heart disease and stroke. So I'm actually a stroke neurologist. I treat patients who have a stroke. I try to prevent a second stroke. But I became more and more interested in what else is important about these risk factors. What happens long term in people who have a lot of these risk factors? So these are the main factors I'm going to talk about. And when I talk about vascular risk factors, this is a set of the things I'm interested in. So what actually happens in the brain when someone has these risk factors that might contribute to risk for dementia and Alzheimer's specifically? So one scenario is certainly you could have a stroke. Stroke can affect your memory. Certainly people with recurrent strokes have more problems with their memory and their thinking. That's one possibility. In addition, we know people who have changes that look just like stroke in the brain, but they never knew that they had a stroke. So someone might get a brain MRI and their doctor says, oh, it looks like you've had a silent stroke, and I'm putting that silent in quotes because it turns out if you have a lot lot of those, it's not so silent, it affects your cognition. People can have these stroke-like changes in the brain from these vascular risk factors. In general, if your blood vessels are diseased, your brain is not getting enough blood flow. I mean, you know that can be harmful for the brain, can lead to volume loss, as well as these stroke-like changes. And then finally, not finally, because there's a lot of other possible mechanisms, but another big thought is one of the jobs of the blood vessels and the vasculature is to drain toxins out of the brain. So the veins and what's called the lymphatic system is a system that we think is supposed to drain toxins from the brain. And if your blood vessels are damaged and you're not draining well, you might not get rid of toxins like amyloid. So it might be more likely that it builds up. So this is a way that at least theoretically in animal studies and other research that these things might be linked and why it's important to study them. So the topic today was the life course. So I really want to talk about risk and prevention across the life course. So there's an increasing body of evidence, and I'm going to share some of our own data, that vascular risk factors are especially important if you're looking at their association with cognitive problems, cognitive decline, and dementia when you consider them from middle age. And what this means is that your risk factor status when you're middle-aged, so 35 to 65 is what that National Academy's recommendation said. They actually called me after I spoke at this panel and made recommendations, and they called me to say, what is middle age? So that's the question I get asked most frequently. So 35 to 65 is sort of a reasonable estimate. So middle age is really such an important time period for making sure these risk factors are under control. In addition, things change over time. So risk factors change, treatment guidelines change, which I'll talk about a little bit. And if there's changes in your risk factors or changes in the way it's being treated, each person may differentially manifest cognitive problems and dementia. So a blood pressure in one person may be less well tolerated than it is in someone else. And similarly, a blood pressure in someone who previously had a different blood pressure is going to mean something different in one person versus another. And I'll tell you more about that. So high blood pressure, let me start off with that, because this is really a particularly important risk factor. It's the strongest risk factor for stroke, and in terms of these vascular risk factors, it's very important for risk for dementia. So this graphic from the NINDS, you can't see the small print, but it says dementia and stroke are even, or it says high blood pressure is even riskier, and then it says dementia and stroke are both possible side effects from high blood pressure. I'm not recommending that anyone do this as an alternative. Physical activity is good. This might be a little excessive, but certainly high blood pressure is problematic for both stroke and dementia risk. You may be aware that there were new guidelines for high blood pressure that were published 2 years ago. So in 2017, the new official recommendations for high blood pressure showed that a level that was previously considered borderline was now considered high blood pressure. So stage 1 high blood pressure, they're describing above 130, stage 2, so that's sort of early high blood pressure. Hypertension stage 2 is now 140 over higher. That used to be considered pre-hypertension. So what this means is that suddenly many more people in the population, many more people in this room, I would venture a guess, are suddenly diagnosed with hypertension who never had it before. So what does this mean? I said earlier that your blood pressure change over life and what your blood pressure was when you're younger may make a difference in how that blood pressure affects your brain. This is probably especially important for all these people who suddenly have a new diagnosis of high blood pressure. And we need to think about this when we realize that your body doesn't know that there's new guidelines. Your body's used to a certain level of blood pressure. And it may be that you have to think about what your life course blood pressure has been. And I'll talk a little more about this. So we know, so I'm going to tell you a little bit about the ARIC study. So ARIC is the Atherosclerosis Risk in Communities study. It's a cohort that similarly to Framingham was initially designed to look at atherosclerosis and its risk factors. So looking at risk factors for stroke and heart disease. It was started just over 30 years ago with 16,000 people from 4 sites across the country. It's a mix of black and white participants from these 4 communities. And we've seen people serially. We talk to them on the phone. We do in-person visits. We do cognitive testing. We do brain imaging. We learn a lot about these people. It's another tremendous group of volunteers who are selflessly spending a lot of their time giving us a lot of information about their brains and their brain health, and in addition about their cardiovascular health. And what we found, because we have this long-term follow-up, is that we can look at long-term trajectories of cognition. And people who had high blood pressure when they were middle-aged, so the first time that we saw them when they were 45 to 64, have steeper cognitive decline than people who did not have high blood pressure. Some of you may notice, how come there's this dot here? These are blood pressures, the people who had really high blood pressure and middle-aged, how come we don't see this steeper amount of decline? The reality is there's very few of them who are still alive 20 years later. So if you had blood pressure in the 160s, 170s when you were middle-aged, those people aren't really around to still be in the study decades later. So high blood pressure, in a fairly linear way, higher blood pressure was worse for your decline in your cognition. Everyone declines a little bit with time, but high blood pressure really made it worse. In addition, we know that high blood pressure in the same study is associated with a higher risk of dementia. So this is using the old definitions, but either way, pre-hypertension, so what's now early hypertension, or hypertension, high blood pressure, were both associated with a higher risk of dementia over 25 years in this group of 16,000 people from communities across the US. So about a 30% increased risk if you had borderline hypertension, closer to a 40% increased risk of dementia at any point in your life if you had high blood pressure. And again, this is important because we know how to treat high blood pressure. We know how to screen for high blood pressure, and this is, right now, this is an area where we certainly know much more about than the amyloid-related Alzheimer's-specific treatment. So I mentioned that life course is important. Those studies were from midlife, when we showed relationships with midlife. If you look at someone's blood pressure when they're older, we don't see a similar relationship with dementia risk or with cognitive change. So what that means is your blood pressure when you're 70 to 90 is not related to what your cognition has been doing over the past 2 decades. It really is midlife that appears to be most important. I mentioned that it's important to think about these new guidelines. It's important to think about where someone's blood pressure has been because changes may have different effects on different people. And part of that is because in your brain, your body gets used to a certain level of blood pressure. It's something called cerebral autoregulation. And if your body is used to a certain level of high blood pressure, then you sort of shift the response of your brain, of the blood vessels, to make sure you get enough blood flow to your brain. And if you suddenly drop blood pressure too low, or you drop blood pressure lower than your brain is used to, then you might have problems, which could lead to cognitive problems, theoretically even lead to stroke. So this is not meant to say that people's blood pressure shouldn't be lowered. It's meant to say that each individual may have a different effect of changes in blood pressure over their life course. So in this study that was published recently, we found that people who had high blood pressure in midlife and then had low blood pressure in late life, so this is this top curve on these graphs, had the greatest risk of dementia. So again, high blood pressure in midlife, and then in late life, their blood pressure was 90/60 or lower, so reasonably low. By the way, almost all of those were on blood pressure medications. Those people had the highest risk of dementia. The people who had high blood pressure the whole time still did badly, but not quite as badly as that group. And people who had lower levels of blood pressure did the best. So what about, I keep talking about midlife, and the reality is midlife is what I'm telling you about because that's what we know the most about. We don't know a whole lot about how important these risk factors are at younger ages. So a lot of European studies have the benefit of having birth cohorts, meaning they recruit people when they're babies, they follow them from birth, and they follow them to older age. And so this is a study suggesting that at least looking at outcomes like brain volume, so looking for some of that neurodegeneration and atrophy that we saw a little bit about before, that people who had high blood pressure even before middle-aged, so at early adulthood, had smaller brain volumes later in life. So my suspicion is we have to pay attention to this earlier. We know that as our younger population, meaning adolescents and young adults, are getting more of those vascular risk factors, things like obesity and diabetes, we need to pay attention to their health. I'm going to talk about diabetes and obesity in just a couple slides, but this is one of the few studies that really looks at that earlier life period. This is a very active area of research we need to understand more about. So what about diabetes? Diabetes is less common than high blood pressure, but certainly something that's very important for cognitive decline and for dementia. You might have noticed I had a graphic earlier that I didn't dwell on, but diabetes was a risk factor that was listed in the late life category. It's important basically at any point throughout life. What's important to point out here on this graph is that diabetes is not that common, but it turns out that undiagnosed diabetes is much more common than we realize. It's undiagnosed. So there are many more people in the population, nearly 15% in some of these age groups and a little higher even in 65 to 70-year-olds who don't realize they have diabetes, in addition to the smaller percentage of people who do. So this is important because it's certainly still going to be a risk factor for brain aging, even if you don't know that it's there, and probably even more so because you're not treating it. So we know that diabetes is associated with steeper cognitive decline over 20 years. Again, looking at midlife, people who had diabetes had steeper decline, and people who had worse controlled diabetes, so this is the hemoglobin A1C, among people with diabetes, people with worse control, higher hemoglobin A1C, had even steeper decline, and even among people without diabetes, within the normal range of hemoglobin A1C, we see a little bit steeper decline in people who have worse control of their glucose within that range of hemoglobin A1C. Diabetes is also associated with a higher risk of dementia, nearly a doubling. So if you have diabetes in middle age, you have a 77% higher chance of getting dementia at some point during your life. And I just want to point out that this is not dissimilar from the risk that we found from ApoE. So we talked about apolipoprotein E, the particular form of the gene that's associated with an increased risk of Alzheimer's disease and is the strongest known genetic risk factor for Alzheimer's. In our study, about doubles the risk of dementia. This is pretty close to the risk of diabetes. We don't currently have anything we can do about ApoE, but again, we can do something about diabetes. What about other heart disease and stroke risk factors? So smoking, we know, is certainly associated with cardiovascular disease and stroke. It's associated with about a 40% higher risk for dementia in our studies. For people that are current smokers, meaning they were still actively smoking in middle age when we saw them, the risk appears to go down for people who had quit and were no longer still smoking. High cholesterol, we see some evidence, not as strong as diabetes or high blood pressure, but people who had high cholesterol in middle age had more decline in their cognition over time. So what about obesity? A question was asked earlier about the importance of physical activity and obesity, and I'm going to talk about physical activity, and I agree that in general it's better to be physically active and a little bit overweight. But in honor of Halloween coming up, I wanted to scare you guys a little bit with this next series of slides. So this is a map. Many of you may have seen this, but it still packs a powerful punch. So I mentioned that I'm worried about the future in terms of younger population and seeing more problems with risk factors for heart disease, stroke, and ultimately dementia. If you look at this graph, just to orient you, the darker blue represents states where 10 to 14% of people in those states are considered obese, and that means a body mass index of over 30. And I'm just going to whiz through these. You'll notice some new colors have to be introduced onto the map. This is every year, every slide is another year. Dark blue is now 15 to 19%. This is 1996. Now we're above 20%. Orange is above 25% of the population of those states is obese. This is 2005. We have a red for over 30%. Oops, that's the end of my scary set of maps. This is actually terrifying. That's 2010. So I'm glad it doesn't go to 2019 because it would be even more terrifying. There is obviously an obesity epidemic in this country, and we know that this is important, especially in middle age, for risk of dementia. So in this particular study, obesity, again, in middle age, was associated with a higher risk of dementia over the subsequent decades. Obesity is a tricky one where life course becomes especially important. And I want to show something here. So in this study, these are people, red line is people with dementia, blue is people without dementia. And in general, as people get closer and closer to a year of a dementia diagnosis, which is here on this graph, so these are years prior to dementia diagnosis, this is 28 years before, you'll notice that the weight, this is the body mass index, starts to go down the closer you get to a dementia diagnosis. So when people are diagnosed with dementia, their weight is often lower. And this leads to something that's called the obesity paradox, where it looks as though weight is protective against dementia, higher weight, meaning that because people with early dementia or preclinical disease for dementia, neurodegeneration, may start to lose weight either related to behavioral changes or other changes from the disease itself, it looks as though the people who have higher weight are protected somehow in later life. My suspicion is it's mostly because of this phenomenon that weight changes in response to the underlying disease. But clearly in midlife, obesity is a significant risk factor that we really need to pay attention to. So what about physical activity? So I realize that my legend is missing here, so you'll have to trust me on this. The light gray bars here are the highest level of physical activity. White are the most sedentary. In this particular study, this is for risk of dementia. So these are lower risks. People that had more physical activity in middle age had a lower risk of dementia. And similarly, in our study, people that had more leisure time physical activity as self-reported, and also sort of a calculation of how much physical activity they did, we found that they had more preserved cognitive function. So no physical activity, they had the greatest decline on these same tests over 20 years, and people that had the highest level of cognitive function did the best in terms of the highest level of physical activity in midlife did the best in terms of their cognitive performance over the next 2 decades. What about diet? So I'm delighted that we had a Mediterranean diet for lunch today. In addition to the discussion about fish, there is some evidence that a Mediterranean diet is especially protective in terms of, certainly we know it's protective for stroke risk, and there is some evidence that it may be protective for dementia risk. This top line here is the sort of most representative Mediterranean diet. We've tried to study this in our own studies, so the ARIC study that I mentioned, where a lot of my work has been done, was in 4 U.S. communities, so suburbs of Minneapolis, Jackson, Mississippi, Winston-Salem, North Carolina, and Hagerstown, Maryland. We tried to approximate a Mediterranean diet by observing what people reported that they ate, and we couldn't really find anyone that ate anything close to Mediterranean diet. So it turns out that this is harder to study here in the U.S. because many people, unless you're putting them on a dietary intervention, it's not really what most people are eating. The DASH diet is another one that's been shown to be associated with better cognition. So in general, if we think about risk factors for dementia, we know that risk factors are important to control. People don't want to have strokes. People don't want to have heart attacks. But is there something that's particularly important in the way that these vascular risk factors might affect risk for Alzheimer's disease in particular? If we have an amyloid-specific agent treatment that's coming in the future, does it matter if this other stuff is going on, the other risk factors? And I think that it is for a couple of reasons. So one, with this study that I'm about to describe, we see some evidence of a direct link not only between vascular risk factors and dementia diagnosed clinically, but the actual changes in the brain that are associated with Alzheimer's, so amyloid deposition. So really in understanding how these things are connected, I think it makes a big difference whether high blood pressure, diabetes, obesity are just causing problems in the brain that are happening in parallel to Alzheimer's type changes, and both together make you more likely to look clinically demented, or is there some more direct causal link? And I'm an epidemiologist, I can't show causality here, but what I want to show you is that we found in people in that ARIC study, we followed 346 of them had an amyloid PET scan, so one of the isotopes that you learned about earlier from Dr. Jagus. And what we found is that, and these were people without dementia, that the more vascular risk factors you had when you were middle-aged, the more amyloid you had in your brain when you were older. So again, people without dementia, some had mild cognitive impairment, but the more risk factors in middle age, the more amyloid you had. And the risk factors we looked at were high blood pressure, diabetes, smoking, high cholesterol, and obesity. So we looked at how many you had, and what we found here is that people in midlife who had 2 or more of those risk factors in middle age, and part of the reason we had to split it into 2 or more and didn't look individually at 3, 4, and 5 is this is another example. People who had 5 risk factors in middle-aged were not around to be in our study 25 years later. If you had 2 or more risk factors, you had nearly a tripling of the odds of having amyloid in your brain in later life, and nearly a doubling if you had 1 vascular risk factor in middle age compared to having none. We do not see the same relationship when we looked at late life, meaning the amount of vascular risk you have in later life doesn't appear to be that important for amyloid. And probably this is because, as we've heard from everyone today, this process takes decades to occur and to accumulate and for these changes to happen. And it may be that we're simply looking at people too late when we look in late life, but that vascular risk is especially important at a younger age In addition, it's possible that people who have vascular risk factors in middle age simply have a longer exposure to those risk factors. So if you have a high blood pressure when you're 40, it's more likely you've had it for decades, and it's especially important. So this is just to make that point even more about the importance of midlife, just showing you this is number of risk factors, 2 plus 1, 0, at our midlife visit, and this is at our late life visit. And as we get closer and closer, the strength of the association gets smaller and smaller the closer to late life, which is when amyloid is measured, that we get. I mentioned that there were 2 reasons that it was important to think about these risk factors, even if we ultimately have an amyloid-specific treatment. Because there's so much mixed pathology, I threw in these 2 slides after we heard the results of the Biogen study to make sure this was relevant to that new information. Even if we know that vascular risk factors, we know there's so much mixed pathology, and many of these studies are in pure Alzheimer's type patients, meaning people that don't have a lot of vascular risk. The reality is that is not what most of the population looks like. It is highly likely that ultimately treatment will have to affect both of these areas, both an amyloid Alzheimer's specific pathway as well as a vascular specific pathway. And if the vascular pathway is prevented early, maybe we can avoid some of that amyloid specific pathway. So this is just a study, the same study where I showed you the PET scans in ARIC, where we followed people for cognitive change, looked at dementia cases. I told you they weren't demented, but we've continued to follow them in the study. And what we found is that independent of brain amyloid, high blood pressure was still important for your cognition, and independent of hypertension, your amyloid level was still important for cognition. So what that means is that these 2 things are still going to be very important in determining how you do. We can't only treat one of them. Obviously, we should treat the one we know how to treat now, the high blood pressure, but ultimately it may be really important to treat both. This is looking at late life. Diabetes similarly remained important independent of amyloid and vice versa. So again, we need to continue to treat the things we know how to treat, even if we come up with a therapeutic way to treat the amyloid pathway. So to wrap things up, obviously, an important part about thinking about prevention is knowing if treatments actually make a difference. So a few people have said today, we know that it's important to treat high blood pressure, and I want to make sure we're all on the same page about what we know and what the evidence is in this area. In the past, and actually at the time of that National Academy's publication, there were no clinical trials showing definitively that treatment of high blood pressure nor treatment of any of these other risk factors made a difference in preventing dementia. They had good observational evidence, and they had this decades-long information that midlife risk factors were really important. But relatively recently, the SPRINT MIND trial was published, and I'm going to show you the results on the next slide. But what was exciting about this, so this was a study where people were randomized to sort of normal control of high blood pressure, which was keeping them at a goal something under 140 millimeters of mercury systolic for the top number, versus aggressive control under 120 millimeters of mercury for the top number. So randomized a large population to normal control versus this aggressive control. The study was actually stopped early due to a clear benefit for cardiovascular outcomes, a combination of heart disease, stroke, heart failure, et cetera. So the study was stopped early, which meant that the cognitive part of it had to be stopped early as well. But after about 3 years of treatment, they looked at people and said they were carefully following their cognition, and they found that although they did not see a reduction in dementia, which was their primary outcome they were interested in, so again, no difference, statistical difference in dementia rates for people with normal blood pressure control versus aggressive blood pressure control, they did see a reduction in mild cognitive impairment and in the combined MCI plus dementia category. There is certainly, I am the first person to say if you don't find your primary outcome in a study, then you shouldn't get too excited about it. This, I think, is clearly an example of a study that was a little too short. In my mind, I would love it to be started in middle-aged and have a 3-decade study. No one's ever going to do that in terms of a clinical trial. But I think this is a really exciting area. We have a signal. We see something that actually reduces MCI and dementia together, and I think is very hopeful for thinking about prevention in general. The other area that's been exciting and where we think there's some signal in terms of lifestyle interventions other than high blood pressure is the FINGER trial. So this was a trial in Finland where people with MCI, with mild cognitive impairment, were randomized to get this multi-domain intervention. So you've heard about some multimodal interventions today. This means that they were counseled on their diet, exercise, they had some cognitive training, they followed their vascular risk factors to make sure they were being well controlled, versus more standard therapy. And at least in their early cognitive change trajectories, meaning they looked at how people changed over 2 years, they found that the multimodal intervention group did better, had less cognitive decline than people who were not in that multimodal intervention group. The Pointer trial that you heard about is a new study in the US. So the FINGER trial used a very Finnish diet. There's a whole lot of herring in it. And the Pointer is a little more culturally appropriate for the US, which is hopefully going to answer a lot of exciting questions as to whether this multimodal approach is going to help. Again, it may be that it ends up being multimodal plus whatever is happening on the amyloid side as the ultimate cocktail in terms of how to treat this, but I think we need to address this from as many different angles as possible. PREDIVA is listed below because it was another failed attempt at a multimodal trial, and I don't mean failed because it wasn't done, it just failed to show a benefit. So this is not a slam dunk, but certainly very exciting and promising. So to conclude, what are the take-home messages that I want to leave you all with? Certainly, we know that risk factors for heart disease and stroke appear to also be risk factors for cognitive decline and dementia, and many of these are modifiable. Normally, I traditionally give sort of my spiel as I'm doing a talk about this topic, saying there's nothing else we can do for Alzheimer's, nothing else we can do for dementia, and these are important things we know how to treat. I'm excited that there may be something else that we can do for Alzheimer's, we'll see, but regardless, it is extraordinarily important to do what we know, to treat things that we know how to treat, because they're probably both important. They may directly lead not only to cognitive problems, but even to changes in the brain that contribute to Alzheimer's, like amyloid deposition. We know that blood pressure in particular, there is good evidence that aggressive treatment of high blood pressure can reduce the risk of MCI and dementia. My one caveat to that is our data that showed that change in blood pressure over the life course is not going to be the same for everyone. And so you really need to talk with your doctor about whether you're a candidate for that more aggressive control of high blood pressure. And in general, there's this potential role of this overall lifestyle modification, focusing on overall health, really may be very important in preserving brain health. And then finally, as we're deciding how to treat people as an ultimate, hopefully we have a cure for this disease, as was mentioned several times. I do think we're going to have to attack this from all angles because there's so much mixed pathology, and this disease is rarely an isolated Alzheimer's pathology or an isolated vascular pathology. So here's some of my acknowledgements. I have fabulous colleagues and a lot of fabulous trainees who have done a lot of this work, and most of them are mentioned here. I do want to reemphasize the selflessness and amazing contributions of ARIC participants and staff who have now been followed for 30 plus years, and we've just been funded for another 4 annual visits with them, and they're really extraordinary. And of course, my funding sources, and I'm happy to take any questions. Thank you.